Assalamualaikum warahmatullahi wabarakatuh. Good morning, good days, and salam sejahtera to all the participants from Malaysia, from CMO Network, and from the affiliated country. Welcome to IMR CMO Webinar Series 2020. For those who are first time here and who started to follow the IMR CMO Webinar Series, this webinar was initiated to share knowledge and experience and present a research finding in the biomedical field. For today's session, the highlight is Zika with the theme Zika in Malaysia, what has been made known. And I'm Tengku Rogaya Tengku Abdul Rashid, Research Officer from Virology Unit Infectious Disease Research Center, Institute for Medical Research. I will be the moderator for today's session. Okay, before we begin our presentations, I would like to announce a few housekeeping messages from the Secretariat. Okay, we will not taking any questions during the presentations, but you may post the questions using the link shared in the YouTube channel. And the question and answer session will be conducted at the end of the second presentations. And the attendance link is also provided for those who like to receive an e-certificates, and you may find the links in the YouTube channel. Okay, you may subscribe or please subscribe to our National Institute of Health Malaysia YouTube channel to receive an updated of new posts. Okay, as a brief introductions of today's theme, what is Zika and why is it matter? Zika virus, which has been identified around 65 years ago, is one of the arboviruses which is spread to human through the bite of infected mosquito, primarily by Aedes species. And most of the people infected with this virus won't show any symptom or just a mild symptom such as fever, rashes, headache, or joint pain. However, during the 2015 and 2016 Zika outbreak, the virus has been associated with the increasing number of microcephaly in newborn, and also other severe brain defect cases, and also increased number of Guillain-Barré syndrome. Okay, during the outbreak, many studies related to Zika has been conducted. And Malaysia, as one of the country with high number of Aedes mosquito, is also no exceptions. Okay, without further ado, let listen to our presenter presentations of what research has been conducted and what is the finding. Ladies and gentlemen, joining me today are two speakers from Infectious Disease Research Center, Institute for Medical Research, Mr. Muhammad Afif Azizan and Ms. Rozia Ali. Okay, let me introduce you to our first speaker, Mr. Muhammad Afif Azizan. Mr. Muhammad Hafiz is a research officer in virology unit. He obtained his bachelor degree in biomedical science from International Islamic University, Malaysia, and master's degree in molecular and cellular basis of human disease from University of Sheffield, United Kingdom. And currently, he is working with SARS coronavirus 2 and also studies of Zika virus in pregnant women, and also studies of Zika virus in non-human primate. Again, his research interests are molecular and serology field. Okay, today Mr. Afi will be sharing his research experience and the outcome of the Zika project in his presentation entitled Cross-Sectional Seroprevalence Study of Zika Virus Infection in Selected States in Malaysia. Please welcome Mr. Muhammad Afif.
So thank you, Mrs. Rogaya, for a quite brief introduction. Even introduced to us the a bit about Zika. So for now, I think most people or everybody should have heard about Zika virus. What can it do to the body, especially those who are infected by the Zika virus could go resulted in the microcephaly. Okay, so for starts, let us see the overview for the project. So back in 2016, there was a massive outbreak of Zika in southern region of America country, where particularly Brazil has badly affected with over 1 million cases detected. And in conjunction to that, there are high number of microcephaly cases were detected. So for that matter, in the 1st February of 2016, Zika outbreak has been declared by World Health Organization, WHO, to be the public. We also suffer a bit from the Zika outbreak. For example, in Singapore, we have 455 cases, confirmed case of Zika virus. And in Thailand, we have the 368 confirmed cases between January 2016 and December 2017. However, in Malaysia, we have 8 confirmed cases out of clinical sample that we screened around 4,043 samples between June 2015 and December 2017. So, why did this happen? And how can this happen in Malaysia? So, are we so protected against such virus? So, that's what we want to find out in the study. So, in response to this question, so we set up a team from IMR, consists of epidemiology and biostatistic unit, virology unit, and also medical entomology unit. So we went on to do this population-based sero survey, which is also a community surveillance. We went to 3 different states in Malaysia, namely Johor, Sabah, and Kedah, between April to July 2017. So Johor and Sabah was picked based on the confirmed case happened within the area, and Kedah was chosen because of the to be our negative control for the study. So to know more and understand more regarding the Zika history in Malaysia, so let's take a look at the history of Zika in Malaysia. So the first case ever reported was from Smithburn in 1954, where he collected a few samples, blood samples types, and he tested on them, and some of the blood samples were turned out to be positive for Zika. So in later years, 1966, we were able to isolate the first Zika virus in Malaysia from Aedes aegypti. So in subsequently 30 years after that, we managed to do some study regarding the human and primate samples in Sabah. But then, since then and after that, there has been no comprehensive Zika study or Zika seroprevalence ever did in Malaysia. So for the study, we want to know more on Zika affecting our population. So the objective for the study is that we want to determine the seroprevalence of Zika virus in Malaysia. So we know that Zika virus has a few strains which could affect in different ways. So it would be interesting if we could determine the circulating strain and also characterize the local Zika virus in Malaysia. So this is how we do with the samples. From the study, we try to collect 2 types of samples. First is blood and the second is urine. So for the blood, we will collect the 3 ml of blood, and then we process the blood and take out the serum. So from the serum, we proceed with the Zika IgG ELISA, and the same sample will be proceed with the Zika IgM sample. And whatever we found positive in Zika IgM will be proceed to Zika RT-PCR, and whatever positive from RT-PCR will be proceed to viral isolation and subsequently sequencing the virus. So throughout the studies, we managed to collect samples in total of 1,261 samples. Kedah being the highest sample collection at 464 samples, followed by Sabah 409 samples, and the list is Johor, is 388 samples. So let's take a look at the first state of the study, which is Johor. So Johor is located in the southern region of Malaysia. So we can see that from the map, Johor is divided to several localities. So within the map, we also see that there are different colors for Johor localities. The different colors indicates there are different kind of Zika activity happens within the area. So the darker the color is, more activity of Zika virus reported. So let's take a look at the localities of the Johor. So from the slides, we can see that in Johor, Kota Tinggi has the highest Zika IgG exposure compared to other localities at 33.3%. Meanwhile, the Johor Bahru and Pontian is among the lowest of the Zika IgG compared to other localities. So for IgM, we can see that Mersing has the highest at 14.3, while Kota Tinggi has recorded none of the Zika IgM detected. So instead of, besides the Zika ELISA, we also did dengue ELISA to the samples, such as dengue IgG and dengue IgM, just for comparison. So we can see that for dengue IgG, we have prominent results compared to Zika IgG in Johor, while for dengue IgM is lower compared to Zika IgM in Johor. So those IgM we subjected to the real-time PCR, and we are able to detect Zika RT-PCR for 0.3% out of total sample. So we move on to the next state of the study, which is Sabah. So you can see from the map, there is also no activity of Zika virus ever detected. So some of the state has the case, and we can also see the confirmed case within the Sabah. So the locality in Sabah, we can see that exposure of the Zika IgG is quite high. As you can see, there are several localities that marks 50%. 50%. So we can see that the exposure of the Zika virus in Sabah is quite high. And from the slide also, we can see that some of the localities shows 0 or none reactive IgM within some of the localities. So again, the same sample for Zika ELISA, we proceed with the dengue ELISA. So the result for Sabah, we found that dengue IgG is also prominent than Zika IgG, while dengue IgM is lower compared to Zika IgM. So we proceed both IgM to do for real-time PCR, and we found that 0.5% are able to be detected from total of 409 samples. So we move on to the last state of Zika study, which is in Kedah. So Kedah is located in northern region of Peninsular Malaysia and also bordering the Thailand. So if you remember from the introduction slide, I would say that Kedah was chosen to be our negative control, but judging from the map, we can see that almost all of the localities in Kedah has been infected with Zika virus. So we can see from the colors of the map that almost all has Zika virus activity. So let's take a look at the localities in Kedah. So in general or in average, Kedah has a high exposure of Zika IgG compared to other states, we can see that in Padang Trap, it's the top of the chart, 78.3% is also high within the 3 states. So we can also see for IgM at 55.6% in Pulau Tuba is also the highest within the 3 states. So interestingly, when we subject the samples to do for Zika, to do for dengue ELISA, so we able to found out that dengue IgG is much lower to Zika IgG in total. So this is somewhat true to how we pick Kedah to be our negative control based on low endemicity of dengue. And dengue IgG in Kedah also is the lowest compared to the 3 states before. And dengue IgM compared to Zika IgM also is the lowest within the 3 states. So we subject those IgM samples to Zika real-time RT-PCR and none were able to be detected. So to calculate the seropositivity rates among the 3 states, so we divided the samples between IgM only, IgG only, and also some of the sample when we did the testing, it detects the IgM and IgG both. So we distinguish them and we put in graph, as you can see. For IgM, Kedah recorded as to be the highest for Zika IgM seropositivity rate at 3.2%, and the lowest is Sabah at 2.0%. But for IgG, we can see that Kedah is, of course, the highest at 46.1. But then the lowest for Zika IgG is Johor at 16.0%. So from the seropositivity rate, we calculate the seroprevalence for Zika infection in the 3 states. So Kedah has the highest seroprevalence within the 3 states, which is 52.8%, followed by Sabah 36.9%, and also Johor at 19.8%. So with that, we conclude that the highest seroprevalence of Zika IgG is Kedah, and then followed by Sabah, and then Johor. For seroprevalence IgM, the highest will be in Kedah, and followed by Johor, and then Sabah. But for dengue IgG, the highest will be in Sabah, and followed by Johor, and lastly is in Kedah. So I want to address few limitations of the study. The first is throughout the study, we did not manage to isolate the Zika virus, maybe due to low viral load, and because we did not have the virus, so we cannot proceed with the PRNT, which to determine the antibody meant for Zika virus. And since we don't have the virus also, we could not subject the samples for next gene sequencing to determine the circulating strain of Zika virus in Malaysia. So with that, I end my slide and thank you.
Thank you, Mr. Afif. If there are any question pertaining his presentation, you kindly submit it to using the link provided in YouTube channel. Okay, next I would like to introduce our second speaker, Ms. Rozia Ali. Ms. Rozia is the research officer in Medical Entomology Unit since 2011. She obtained her bachelor degree from University of Malaya, mastering in genetic and molecular biology. Later, she obtained her master's degree in molecular biology from the National University of Malaysia. She's also the alumni of Diploma in Applied Parasitology and Entomology, Semiotromed, Malaysia. Okay, Ms. Rozia area of expertise and interest are studies of arboviruses, mosquito, forensic entomology specialized in morphological and molecular identifications of important Diptera species. She's also actively involved in Zika project. Okay, to name few, she involved in identifications and isolations of Zika virus from field collected mosquito during the 2016 Zika outbreak. And currently, she's working on the vectorial capacity of non-Aedes species of Zika virus. Okay, this is our privilege to have Ms. Rosia with us today to share her research experience and her finding in her presentation. Vector surveillance and entomological mapping associated to the Zika virus in Malaysia. Please welcome Ms. Rosia.
Thank you for the kind introduction, Ms. Tengku Rogaya. Assalamualaikum, salam sejahtera. Good morning to everyone. I'm Rosia from the Medical Entomology Unit, Institute for Medical Research IMR, Kuala Lumpur. Today I will present my research finding, and my presentation will focus on the entomological surveillance associated with Zika virus collected from the selected sites in Malaysia. As mentioned by the moderator, Zika virus is a mosquito-borne flavivirus that goes under the family of Flaviviridae. The virus was first isolated and identified from the rhesus monkey in 1947, and later it was first isolated from the vector mosquitoes, which is Aedes africanus, which were collected from the same locality in Zika Forest, Uganda. Given the fact that Zika is transmitted primarily through the bite of the infected female Aedes species mosquito, CDC has reported the several routes of transmission during the global outbreak happened in 2016, which include placental transmission, which was from the pregnant woman to their babies, through sexual transmission, and also through blood transfusion. So what happened in Malaysia was, in the 1960s, a group of researchers has reported the first isolation of Zika virus from Aedes mosquito, from the vector of mosquito, which is Aedes aegypti, which were collected in Bentong, Pahang. And later, there's one confirmed case of Zika fever reported from a German tourist who visited Sabah back in 2014. And later in September 2016, Singapore has reported a massive outbreak of Zika infection, and followed by Malaysia, which also reported 8 confirmed Zika infection, which have a patient who have a travel history to Singapore, and some of the patient didn't have any record going out from the country during that time. Okay, because of the situation in 2016, the Ministry of Health has alerted the authorities to the need to be prepared to control the spread of the virus within the country, including IMR. Thus, IMR has conducted studies, and one of it was to determine the entomological aspect of associated to the Zika virus. And in this study, 3 states was chosen, namely Johor, Sabah, and Kedah. The study was started with sample collection, and we collect the mosquito, including the adult mosquito and larva samples. And after that, the sample were processed by sorting according to the sex, species, and location of the study area. And sample were transported back to the laboratory to detect the Zika virus using real-time RT-PCR technique. For sample collection, we use several types of traps and technique throughout the study conduct. Adult catching was using BG Sentinel trap, CDC light trap, sticky OV trap, resting catch technique, and also handheld aspirator, or what we call as bazooka. Each trap or technique was designed for a specific type of mosquito behavior as well as mosquito species. For example, BG Sentinel trap was mainly used to catch Aedes species, and CDC light trap was used to catch mosquito during their peak hour peak hour of activity at night. And the setup for each of every trap was also different, such as sticky OV trap was placed indoor and outdoor of the premises, and we leave around 2 to 4 days upon collection of the samples. However, for the CDC light trap, completely live during outside of the premises during night until dawn, and the collection of the samples was conducted on a daily basis. We also conduct a larva surveillance during the study to collect the immature stages of the mosquito. Larva surveillance also called as a search and destroy, where we search for any potential breeding sites, and examination were conducted. And after the collection of the larva sample or any immature stages of the mosquito, we destroy the breeding sites, or we conduct larviciding activity if possible. And finally, the immature stages of mosquitoes were also collected by OV trapping technique, and the OV trap were placed indoor and outdoor of the premises, and we collect after 3 to 4 days upon collection. The samples collected were brought back to the laboratory for Zika virus RNA, and approximately 25 mosquito were pulled based on the sex, species, and the location of the study areas in the same tube prior for RNA extraction. And the Zika virus was detected by conducting the RT-PCR or real-time PCR technique, and later the data for the species composition and the minimum infection rate was analyzed. Species composition data from the study has indicates that Aedes albopictus was the most prevalent species in Johor, and this species showed a high number of captured for both larva and adult mosquitoes. And this study also observed that larva surveillance technique catch the highest number of sample and compared to OV trapping technique. And in addition, for adult samples, this study also managed to catch high number of Aedes albopictus by resting catch technique. And the same pattern was observed for the larva collection in Sabah, as Aedes albopictus was the most common species captured compared to the other species. And from the result, we can see that larva survey catch the highest Aedes albopictus, and plus we have adult mosquito from the resting catch technique, where Culex statinoryncus is the most common species captured in this is in Sabah, in Johor. Okay, let me repeat. The same pattern was observed when we did the sample collection in Sabah from with Johor, as Aedes albopictus was the most common species captured compared to the other species. We did collect using larva surveillance and OV trapping, and for the adult mosquito, Culex statinoryncus from the resting catch, from the resting catch showed a high number, from the light trap showed a high number compared to other species. And in this study, we also observed that all trap and technique that we use in Sabah managed to catch Aedes albopictus species from all the technique that we use. And sample collection in Kedah also showed that Aedes albopictus was the most captured of larva sample, but Culex stratinorhynchus was the most prevalent species in adult composition compared to the other species, especially Aedes albopictus. And real-time PCR was conducted to detect the Zika virus in mosquito, and the Zika virus detection was obtained showed that 5 species of Aedes was detected with a Zika virus. Meanwhile, a total of 6 species of Culex was also positive with Zika virus RNA. And in addition, Aedes albopictus, from the graph, you can see that Aedes albopictus species was detected with Zika virus from all 3 states, and same goes to the Culex stratinorhynchus species, which was positive with the Zika virus from the all 3 states, all 3 states of the study areas. And moreover, the Culex stratinorhynchus from Kedah was also positive with Zika virus RNA, and there was no Zika virus detected from the same species, which is Culex stratinorhynchus, which were collected in Sabah, even though the number of collection was quite high in Sabah. And to note that there are non-Aedes aegypti species showed positive with the Zika virus from all locations in the study area, from the study area. The distribution of the mosquito positive with the Zika virus were mapped together with the human infected case, and as you can see, there were positive mosquito with Zika virus in the same location of confirmed cases in Sabah. However, there is no mosquito detected with Zika virus in the area of confirmed cases in Johor, which is in Johor Bahru. We also went to the confirmed case houses in Kota Kinabalu, Sabah, and the study conduct within the 200 meters radius from the confirmed cases, and the distribution of mosquito with the Zika virus were mapped, and the maps indicate that Aedes and Culex mosquito positive with Zika virus can be found from the surrounding area of both locations. Distribution of the mosquito with the presence of Zika in Kedah also showed that the samples were collected at the area at the high number of human infected case, which is in Padang Terap and Kota Setar. And infection rate for Zika virus in the mosquito also showed that Culex stratinorhynchus has the highest value compared to other species, especially Aedes albopictus. In summary, our study on surveillance of mosquito distribution at the area of Zika infected case showed abundance of Aedes albopictus species compared to other species, and we also reported that detection of Zika virus in several species of Culex mosquitoes, and this study also suggests that the Culex might play an important role as a potential vector in Zika transmission. To conclude, considering the detection of Zika in Culex species, more research need to be conducted to confirm the transmissibility of the virus in the vector. That's the end of my presentation, and I would like to thank to Dr. Chong Yung Lin from IMR for the help in the map construction throughout the study conduct. Thank you for your attention. Assalamualaikum.
Thank you, Ms. Rosia. Once again, I would like to thank both of the presenter for their very great presentations and for the very very interesting findings. The correlations between the Zika seroprevalence and dengue seroprevalence in Malaysia, and also the potentials and capability of non-Aedes mosquito as a vector for Zika virus. Okay, we will now move to the question and answer sessions. please submit your questions through the link provided, and I will try to connect you to the speakers. Okay. 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 It seems that we have received a few questions from our audience, and I think we have enough time to answer 3 to 4 questions. Okay. Okay, the first question is to Mr. Afif. Okay, what is the significance of doing dengue IgM in this project, in your project?
So basically, for the project, we want to check the Zika seroprevalence. But then we also know that Zika and dengue is almost identical, so shares the same binding site or binding epitopes for viral entry, and also shares the same vector with dengue transmission. So in order for us to know, to rule out from the study, we want to make sure that the antibody is truly for Zika virus. So the dengue ELISA was meant for to rule out the dengue infections from the study. I think that's the answer.
Okay. Actually, the second questions. Okay, I will choose for Miss Rosia. Okay, how do you determine? Sorry. How you determine whether a species is a vector for a specific virus or pathogen?
Thank you for the question, Puan Tengku Rogaya. How to determine whether species is a vector or specific virus or pathogen? Okay. To determine the status of the specific mosquitoes or any insects as a vector for any pathogen, there's several criteria must be fulfilled. The first one is the insect must bite human or animal, and the distribution of the insect must correspond with the disease distribution. And another one is the abundance of the vector, particular vector we must have abundance of that particular vector at the study area. And these 3 criteria we can get from the field or the in the disease location. However, we must proceed with laboratory or further study to check or to confirm the insect susceptibility to the pathogen infection. And also we have to check the pathogen incubation time must be within the lifespan of the insect or the vector. That's all from me, Puan Tengku Rogaya.
Okay. Another question to Mr. Afif. How do you know that in ELISA, Zika result does not cross-reactive with dengue result? How do you know that in ELISA, Zika? Okay.
Okay, for now, we know that for any seroprevalence study, the gold standard for seroprevalence is PRNT. Since we do not able to isolate the virus, so we cannot proceed with the PRNT. So what we did was we try to subject the sample to the dengue ELISA, and then from dengue ELISA, so we proceed with the IgM, and also subsequently proceed with RT-PCR. So we want to know whether the antibody that we detected is truly meant for the virus. Means that if we're able to detect the Zika antibody, is it truly for Zika virus? So that is where the PCR comes in play. So when we do the RT-PCR for dengue and Zika, so most of the samples come from negative for dengue, and for Zika we are able to detect, I think it's uh, 2 samples from Sabah and 1 samples from Johor. So from that, I know it's not enough to determine the cross-reactivity for the ELISA, but since that we don't really have much samples to go for RT-PCR, so that is at that point of time, that is what we could do. So we just have to run with the dengue ELISA, which is screened with IgG, and go for IgM, and then we go for RT-PCR just to confirm whether the antibody is meant for the virus. I think that's.
Okay, for the next questions is also to Mr. Afif. Do you have any plan of obtaining the Zika virus from clinical sample?
So actually, we plan to do a future study based on this data that we have. For example, in one of the slide in the Kedah states, we have the Padang Terap has the highest of the exposure of Zika IgG, and we also know that in Kedah, Pulau Tuba has the highest of the Zika IgM exposure. So we plan to do this reservoir study because my colleague here, Rozia Ali, has been doing the vector for the Zika. And for us, we screen through community surveillance. So what's left to be there is to know whether the reservoir in Malaysia harboring the Zika virus. So from there, we hope to find the Zika virus. We are able to isolate the Zika virus from the reservoir. Since that from the clinical samples, we could not because of the low viral load. So we were hoping if we do this non-human primate study, we could engage more on the clinical samples which detected for RT-PCR, and if we have more of the sample for RT-PCR and more positive case, so we can select, we can try from those samples to do for isolation, and for that maybe we can do this sequencing and also the characterization of the local virus.
Okay, thank you, Mr. Afif. Okay, the another question is to Ms. Rozia. How will this finding benefit the vector control program if an outbreak occurs in the future?
Benefit to the vector control program. So from the research finding, as we know, each mosquito species have a different behavior and preference in habitat. And by understanding the choice of oviposition and also the mosquito behavior is important for the design, the successful of the control program. And for example, Aedes albopictus breeding site is different from the Culex quinquefasciatus. And also the mosquito behavior, the peak hour, the biting activity is different. So any control program must aim according to the behavior, according to the environment and the habitat of the species. So if in this study we found any new vector or any potential vector that contribute to the disease transmission, the finding totally benefit to the control program. They will adjust according to the abundance of the mosquito, the behavior, and also their habitat.
Okay. Thank you, Miss Rosia. Yeah, we still have time for another few questions. This another question for Mr. Afif. What is better way to quantify Zika virus? How you quantify the Zika virus?
So for any virus, I think the best way to quantify the virus is through plug assay, or we did this viral load PCR. But then, having said that, maybe plug assay is the best to quantify the virus, and then we can proceed with the TCID50 just to check on the infectious virus. So, yeah, I think this plug assay would be the best way to quantify the virus.
Okay. For Miss Rosia, Zika virus found in Culex species. Does this imply that it could be a Zika vector?
Throughout the study, yes, we found several numbers of QLEX detected positive with Zika virus. But to confirm that QLEX species is a vector or potential vector for this species, I have mentioned in the presentation that more study need to be conducted, especially the susceptibility status and the vectorial capacity of the mosquitoes, especially QLEX, because during the detection, possibly because of the accidental feeding of the mosquitoes during their biting behavior, and the technique that we detect the Zika virus RNA was only detect the genetic material of Zika virus, which is RNA. And yes, to confirm it, more research need to be done.
Okay. Thank you, Miss Rosia. I think we take another one more questions to Mr. Afif. Diagnostic test plays important role in disease preventions and provide fast access to treatment. As for now, do we have any rapid test kit available for the public upon the developments of Zika symptoms? Okay.
Okay, for rapid test kit for Zika. I'm not sure regarding the test kit, so I cannot say for sure whether we have developed the rapid test kit for Zika symptom. Maybe.
Okay. I just add on a bit here. For Malaysia, since we are not very what we call that affected with this Zika outbreak, so maybe we are not aware of the existence of that kit. So, and again, as what Mr. Afif mentions, we are not sure whether there is Zika rapid test kit available in the market. Okay, I think that's all the questions that has been submitted. So, and also we are come to the end of these webinars. Okay, I'm afraid we won't accept any more questions from the participants. And I hope that this webinar will benefited all the participants and shed light on research work conducted at our institute, and we hope it can promote an establishment of network among researchers from inside or outside of IMR. Okay, ladies and gentlemen, now we have come to the end of these sessions. I would like to thank all the participants for their support to make these sessions successful. Okay, you may subscribe to our National Institute of Health Malaysia YouTube channel and click for notification whenever there is a new post. Okay, before I conclude, I would like to announce that the next sessions of IMR Simeo webinar series is on 29th of July 2020 with the themes antibiotic resistance in the environment, research needs and gaps. So do mark your calendars. We hope you can join us at the next sessions. Until then, many thanks from all of us at IMR. Take care and stay safe. Thank you.